Okay, so good afternoon, guys. My name is Neil Bardwaj. I'm a consultant HPV surgeon at the Glenfield. I used to be at the General, but we've all moved to the Glenfield. And really, the reason why I wanted to do this talk when Zoe asked me was because a lot of now, because of HPV being at the Glenfield, you guys are being exposed to severe acute pancreatitic patients. And the purpose of my talk really was to sort of outline their journey a lot of times, patients who come in with acute pancreatitis, but also sort of give you an idea of what happens to them before they kind of get to you, what our normal thought processes are when they're in ITU, and when do we intervene and do things to them. So I'm hoping that it would be useful for you. And then I've got some time at the end for some questions, and we can go through specific points that you want to raise from the presentation. So there's quite a bit for us to get through, but I'm sure that we'll get through all of this. So a surgeon can't really give you a talk without talking about anatomy of any kind. We'll go through the scoring systems, the role of imaging. I've got some updates on the fluid resuscitation, pain, nutrition, and the role of ERCP and antibiotics. And then some local complications management, the role of EUS in particular, which I think is quite relevant for patients with acute necrotizing pancreatitis. So where is the pancreas gland? Well, it's in the abdominal cavity. It's surrounded by the stomach, the spleen, the tail of the pancreas, colon, small bowel, liver, and spleen. And so the reason why I want you to realize this is so that in your mind's eye you can think about when people have severe acute pancreatitis with collections, what kind of tissues around the pancreas are likely to be affected. And there's some really major blood vessels around there, and the relevance of that, of course, is pseudoaneurysms. So this is a little bit more of an overview. The body of the pancreas is this bit here. This is going into the tail, and then this is the head of the pancreas with the bile duct running through the head of the pancreas. And the pancreas gland actually is a soft gland because it means all flesh in Greece, or Greek even. So the head of the pancreas lies in this loop of small bowel and this duodenum. And again, this is relevant because when you look at local complications, more really for chronic pancreatitis, when you can get narrowing of the duodenum. But even if you look at acute pancreatitis, you can see that you've got blood vessels that are running very close at the superior margin of the pancreas, so more likely to get pseudoaneurysm in these. You've got the stomach, which is overlying it, so you can get early satiety and local compression symptoms. The tail lies near the spleen, so again, that has relevance in terms of pleural effusions. Your diaphragm is just running over here. So sympathetic pleural effusions, for example, are quite common in severe acute pancreatitis. Only 1 or 2% of the glands are islet cells, which are mainly in the tail, and the rest are acinar cells, which are the exocrine function. The pancreatic duct normally is only 2 to 3 millimeters. It runs through the length of the pancreas gland, and the CVD, as we mentioned earlier, runs through the head of the pancreas gland. So any inflammation of the pancreas gland can also pinch off the CVD, a bit like head of pancreas tumors, and you can get mild jaundice associated with it. But of course, bile duct stones are one of the commonest causes of jaundice in patients with pancreatitis. So it has an endocrine and exocrine function. The endocrine function has over 3 million pancreatic cells. There are 4 main types of cells, which I'm sure you're all aware of. And the purpose of this is to regulate our blood sugar. Exocrine function make up the majority of the cells, and they release inactive enzymes, which are activated by the duodenal wall entropeptidases. Chymotrypsin is converted to trypsin for proteins, amylase breaks down starch, and lipase breaks down fat. So we produce about 1 liter a day. Again, this is quite relevant because if you have somebody who's had duct disruption, you've got up to approximately 1 liter of fluid a day being pumped into a potential pseudocyst over time. And of course, the pancreatic duct, and particularly pancreatic exocrine function, is stimulated by gastrin and cholecystokinin and secretin, which are all secreted by the stomach and duodenum in response to distension. So what is it? Well, it's an acute inflammatory condition of the pancreas, causes local and systemic inflammatory response syndrome. We get over 26,000 admissions in the UK a year, And the modified Atlanta guidelines say you need 2 out of the 3 before we can blame acute pancreatitis as a cause of someone's admission. So you need the typical pain of sort of epigastric pain radiating through to the back. Your amylase and lipase has to be 3 times level of normal, and you've got to have some abnormal imaging supportive of that. So mild is very local or no systemic complications. Moderate, which is the vast majority of our patients, and they don't tend to hit HDU that often, but if they do, it's for a short period of time. And it's the severe persistent organ failures that you tend to see in HDU that can remain for several months at a time. So there are several guidelines that are available. We use the Atlanta or the modified Atlanta being the commonest guideline. And worldwide, etiology-wise, unsurprisingly, gallstones was the commonest cause worldwide in terms of cause for pancreatitis. So the pathophysiology on your left here is normal. This here is a common bile duct with a sphincter ovodi. You've got your calcium and bicarbonate channels, cholecystokinin going into a cholecystin receptor, and trypsinogen to trypsin. So essentially what happens in pancreatitis is you get upregulation of this trypsinogen-trypsin pathway, and that could be because either you've got deletion of the SPINK gene, which of course is the cause in hereditary pancreatitis, up to 1% of patients admitted with those, and of course alcohol works on the cholecystokinin pathway and again converts trypsinogen to trypsin. And then the physical obstruction by a stone causes increased intraductal pressure, or a tumor can cause intraductal pressure, and again as a cause of pancreatitis. There are of course other causes, but I wasn't going to go through get smashed as they're sort of weird and wonderful and we don't see them very often. So you get 2 types of response. You get an inflammatory systemic response and you get a local pancreatic response. And this is the reason why I showed that anatomy side at the beginning with duct disruption, jaundice, pancreatic necrosis, bleeding, sepsis, pseudocyst formation, gastric outlet obstruction are more all anatomical complications that can occur because of pancreatitis. And the more systemic inflammatory response causes multi-organ failure. And we're all aware of patients having ARDS, kidney failure, cardiovascular complications, and of course, ileus and sort of gut failure, really. So elevation of ALT more than 100 and more than 3 times normal is 95% positive predictive value. Amylase and lipase levels tend to peak within 24 hours. Lipase tends to stay in the bloodstream longer. We don't measure it in Leicester, but actually if you've got someone who you think might have pancreatitis and you didn't have easy access to a CT scan to confirm that, then actually measuring their lipase, because that tends to stay in the bloodstream longer, may well be able to tell you that, really. Ultrasound is performed, and that's really to exclude gallstones. And if we have gallstones and radial LFTs, our practice in Leicester is to do an MRCP, as we have easy access, including weekends. And then we've got daily ERCP lists. It was a sunflower trial, which was a nationwide trial that looked at people who had pancreatitis, known bilirubin of less than 50, known gallstones, and whether they should have an MRCP plus or minus ERCP or expect them to pass the gallstone. We actually didn't take part in it because of the fact that we can get easy MRCPs and we have daily ERCP lists. So we didn't feel comfortable enough to leave our patients with a CBD stone without doing something about it and expect them to pass that. And I'll come on to why that is a little bit later on. If you've got gallstones and normal ducts and normal LFTs, then we do an inpatient lap chole, and that's nice guidelines. And that's the reason why we take patients' gallbladders out, because we know that if we let them go home, 30% of them will come in with a worse attack of pancreatitis before we electively get to them to take their gallbladder out. And if they've got gallstones and normal LFTs but dilated ducts on the ultrasound scan, then an MRCP is the way forward. I've said depending on your hospital, because I've given this talk at other places where obviously not everybody has MRCP that useful. We don't tend to use ERCP, some hospitals do. We don't tend to use ERCP for diagnosing bile duct stones, again, because we have such easy access to MR scans. Contrast enhanced CT, there's no point really doing it right in the beginning unless you're not sure that someone's got pancreatitis. If they've got raised amylase with pain, we don't CT them unless they deteriorate rapidly, in which case we may want to CT them to exclude any bowel or any other viscous perforation. But ideally, after 72 hours after admission, really. And it is excellent at localizing site and extent of necrosis. MRCP is very good at evaluating bile ducts in the pancreatic duct. You can also repeat it if there's no radiation. And of course, if you're worried about a pseudoaneurysm or an active bleed, then you can also combine that with angiography. Contraindications, as usual, are critically unwell patients. As you know, MRCPs are not ideal for patients who are in ITU to be sent down for. There's long acquisition times. An average MR abdomen will be between 45 minutes to an hour. And an endoscopic ultrasound scan is fantastic. We've got people who are very good at EUS in Leicester, and they're very good at evaluating the bile duct. Here you can see it on the left, and you can see some tiny little stones in the bile duct. And this is an endoscopic ultrasound scan, a linear scope. And it has therapeutic benefits as well, but it's excellent assessment of microlithiasis that had not been picked up in an MRCP, which can happen if you've got quite severe inflammation of the head of the pancreas. Then sometimes the images are degraded. So there are various scoring systems that have been available. The modified Glasgow, IMRI, and Ranson are the blood-based ones that you'll be aware of from medical school. You can, of course, do individual serum markers. Balthazar is a CT grading or severity. We use the service index and, of course, bedside index for severity in acute pancreatitis. Apache 2 is best validated in predicting mortality, and this is just an example of identifying severe acute pancreatitis. But what we do know actually is that obesity, Apache score greater than 8 on admission, organ dysfunction admission, a greater than 150 of CRP, a Glasgow score greater than 3, evidence of necrosis on admission on a CT scan, and raised hematocrit all help us as clinicians identify patients who will be heading your way. And we should also remember simple things being simple. EWS has a similar predictive power to the Apache and easier to implement in terms of patients who are heading towards HDU. When I go around on a post-take ward round and I see somebody for the first time who's already scoring quite highly on admission, who's obese, who's young, I know that they're going to probably have a rocky course in terms of their acute pancreatitis. So the vast majority of people have a mild self-limiting attack. You prevent their recurrence by either taking out their gallbladder or for them to give up alcohol. That sorts out over 80% of patients that are admitted into hospital. 20% on the other hand will have quite a severe acute pancreatitic attack. That's sort of on the Atlanta modified scale. They'll need you guys, HDU support. And then at that point, you've got to know the indications and limitations of intervention. That's where it's very important that as clinicians and as ITU consultants and doctors, we work together so that we both understand the rationale behind intervening and not intervening at different aspects of a patient's journey. So there's actually 4 main management goals in terms of acute pancreatitis. You've got to treat any organ dysfunction. You've got to identify those early who will develop severe acute pancreatitis. You've got to try and treat the underlying cause, and you've got to, and then following on from that, 20% of patients who develop complications, you've got to deal with them as they come along. So fluid resuscitation, lots of work that's been done, particularly looking at Ringer's lactate versus normal saline. And we know that Ringer's lactate appears to be promising. There is some anti-inflammatory effect, but there is weak evidence. Aggressive early fluid resuscitation has been shown to be possibly a little bit harmful. Colloids are discouraged in septic critically unwell patients, but when I was sort of researching for this talk again, just to update myself, I can see that that's somehow coming back a little bit in vogue with you guys. So I'll be quite keen to get your points on that later on. And goal-directed therapy is still the gold standard in terms of what we should do with these patients. Pain management is interesting, really. There's been really only 9 randomized controlled trials, which is really surprising considering that actually it's quite a common presentation, 26,000 patients a year. Opiates are effective, and we go down the WHO analgesic ladder. We've got to bear in mind a lot of them have an ileus, so they are dependent on a PCA. But it's interesting, there's no RCTs comparing analgesia via different routes, and we just use the simple current pain management guidelines. There was a vogue for a long time ago in terms of nutrition of resting the pancreas, and actually that's pretty much now gone. If you've got a functioning gut, then you should use it really, and whether that's used via an NG, NJ, or oral feeding, that'll be our first preference. We don't like to use parenteral nutrition unless it's absolutely necessary and you've got an obvious ileus. You have catheter-related sepsis, it's high cost related with it. You obviously get bacterial translocation and villus atrophy and increased risk of multi-organ failure. And we know that using there is a reduction in pancreatic infectious complications and a 2.5-fold reduction in the risk of death in patients receiving total parenteral nutrition. NG is easier to place. NG, there was some thought process that it causes less pancreatic stimulation, but there was no evidence on 3 randomized controlled trials and 2 meta-analyses show that there is no difference between NG and NJ. So early versus a late feeding, well, actually, there is a statistically significant difference and reduction in organ failure with early versus late. So we'd like to try and get these people to eat, try and get some nutrition in their gut as long as they've got a functioning gut. The role of ERCP is actually quite important. So if you've got established stone in your bile duct and you've got acute pancreatitis, then you should have an ERCP, assuming you're well enough to go down to the ERCP suite and have it done. I have done ERCPs in the emergency theatre. It's just not a particularly easy thing to do, but actually there is lots of evidence out there which shows that there is improvement, and which is part of the reason why we didn't take part in the Sunflower trial, because we know that actually ERCP is beneficial in patients with CBD stones and pancreatitis. So why would we put ourselves into a trial that says you've got a CBD stone, we should sit tight and see what happens? So there's no evidence to recommend ERCP in cholestasis. It's maybe secondary to edema. And what I mean by that is that you may have patients who've got CBD or transient CBD obstruction because of pancreatitis in the head of the pancreas causing obstruction or pinching of the bile duct. And prophylactic ERCP and sphincterostomy works very well for elderly patients who are not fit enough for a laparoscopic cholecystectomy to prevent future attacks of pancreatitis. But you've got to have good quality imaging. So antibiotics, not really very controversial in this. There's several randomized controlled trials. The problem with all these trials is they had a large crossover control groups to antibiotics, and they were all underpowered, and they were all overestimated infection in the placebo group. So currently there's no evidence to suggest that prophylactic use should be routine, except, and these are all the patients that you guys will see, are the nosocomial infections, cholangitis, and the infected pancreatic necrosis patients. And we'll talk about those in a little bit more detail later on. So local complications of pancreatitis, if you cast your mind back to the anatomy slide, we know that you can disrupt your pancreatic duct, and that's where pseudocysts come from. You can get vascular complications, particularly splenic artery pseudoaneurysms. So we get very, very excited about patients who've dropped their hemoglobin in with acute pancreatitis. First thing we want to do is get them CT angio to see if they've got a splenic artery pseudoaneurysm. Pancreatic pseudocysts, they usually take about 6 weeks to mature before you need to drain them. And pancreatic necrosis infection, open laparotomy, very much out of favor. I saw one during my 10 years as a trainee, and I've not seen any in my 7 years. And usually it's a pre-mortem really, and we use what's called a step-up approach, where I'll go into a little bit more detail. So pancreatic pseudocysts, they contain minimal necrosis, there's minimal infection, and it's just a natural evolution over time of a peripancreatic fluid collections that coalesce. And their main issue is actually pressure symptoms. So you can get gastric outlet obstruction, you can erode into and cause heavy bleeding from the splenic artery. And if it's getting bigger or not resolving, most require intervention. And this is on the right, a classic example, nice thin wall, all the way across is pseudo, so therefore it's not epithelial lined cyst as such, and it's usually communicating, as you can see, with the pancreatic duct. So there's duct disruption here, and then you develop this pseudocyst that is then bounded by the stomach bounded by the colon, which is lower down, bounded by the spleen over here, and sometimes and the duodenum. And classically, because it's sitting just in front of the back wall of the stomach, you can do a transgastric EUS tube and put a pigtail stent in, which then drains this cyst really well into the stomach. Pancreatic necrosis as such is not an indication for intervention. Sterile necrosis can be managed conservatively, and in the presence of infective necrosis, then debridement is indicated, and that's really guided by the patient's clinical function, organ dysfunction, and their CRP. So there's a classical bubble sign that you get. So this is the pancreas has been replaced by this air fluid level. You've just got mushy pancreas here all the way. And this patient's probably going to be very sick, very septic, with quite an infected pancreatic necrosis with air locules in it. So the step-up approach usually means either percutaneous or endoscopic drainage of the pancreatic necrosis, or laparoscopic drainage if that was not possible. You could do small incision minimally access. So a lot of patients may have a percutaneous drain put in. That tract is then dilated, and we drain the infection. And sometimes you can also laparoscope down the tract, or use a video scope to try and get some of the necrotic tissue out. Or you do a cut down. Very slim patients, you can often get into their flank and you'll have a point in access. You could do a cut down and a small incision. So essentially less is more is what we're getting at. Or you could do a combined where you do an endoscopic ultrasound of some part of the drainage, where you can have drainage into the left paracolic gutter, which then needs a percutaneous drain. Open is what we stay away from. We know that it causes massive complications. There's up to 40% mortality associated with it because of the massive sepsis and SIRS response that stirs up. And this is a typical example of how an endoscopic ultrasound uses a stent. So this is a sterile cyst here. There's not a lot of debris. There is over here, just there. A needle is introduced, and you'll see a metal stent, which is a hot axial stent, being deployed via endoscopic ultrasound scan, and that's the stent, sort of the flange there in the collection being deployed. And this is what it looks like. So this is the same patient who'd had that big necrotic collection. They've had this sort of double barrel shape metal stent inserted from the stomach. And then what that allows the gastroenterologist to do is go inside this metal stent from the stomach and pick at this bit of necrotic tissue. And you can see that in this same patient, you've got this lovely, healthy granulation tissue and no obvious evidence of any necrosis. Obviously, the worry with this is that you're picking at it, and if you've got to be quite experienced, you've got to be able to recognize what you're picking at, and then you're not picking up bits of blood vessels or splenic artery and pinching bits of these off, because these are quite sharp pincers. This here on the left-hand side shows a classical necrotic pancreas, and this is the bit that you would pick away to give you healthy tissue. You can also put a pigtail inside this metal stent to allow some of that necrotic tissue to drain away. So that's what a necrotic pancreas looks like. And that's the end of my talk. I'm just going to summarize it for you guys, and then I'm going to open it up to the floor just so that you can ask me any questions. So all patients should have definitive management of their gallstones during index admission if they're gallstone pancreatitic. Less than 20% should be labeled idiopathic. We should look at a cause for people's pancreatitis in more detail. Don't give colloids. I'd be really interested to see what you guys think about this. Manage pain and nutrition early. There's no role of antibiotics unless you've got an infected patient, and CT and intervention is guided by the clinical parameters, and sometimes less is more. I didn't think that I would say that as a surgeon, but actually that's true. So happy to take some questions, guys. Hi, Roshni.
Hi, was it Matt? Sorry, I got sucked into the strike rotors. Thanks, Neil. Yeah.
Sorry, it was a bit whistle stop.
Sorry.
It was a bit of a whistle stop tour, but I thought I needed to get.
It's covered most of the things I was going to say as well. You know, most of my talk was also going to be about fluids and most of it was going to be
I
about
was
fluids and pain and.
I was quite nervous talking about fluids to a whole bunch of intensivists, to be honest, but there you go. As
Well,
a surgeon.
I don't know what Matt thinks, but actually, I was quite surprised when I read about some of the recommendation in the surgical literature about, 500 mils, 250 to 500 mils as a first off bolus, and for the first 12 to per kilo for the first 12 to 24 hours, or I thought that was really, really very generous with fluids. Apparently that's the advised by the American College of Gastroenterologists, that you give that massive volume of fluid over the first 12 to 24 hours. Because in my head,
that aggressive fluid at the beginning is probably going to be more harmful than judicious use. But I'm here to learn as well. I don't know what you guys think about it.
well, I personally think, I don't know what Matt and Zoe would, but I personally think that is far too much, especially in the early stages when you've got to consider capillary leak. You've got to consider, whatever fluid you're going to be giving is going to be leaking out into the tissues, and that's going to be causing more harm, because you are then going to be, you might end up with acute lung injury. And especially these days, when we are able to monitor patients much more at the bedside, we're able to look at EWS, we're able to look at end organ dysfunction, and we're also, I accept that you probably will have less access to do echoes and cardiac output monitors and then base your fluid resuscitation on that. But then it does need to be personalized. I think you can't have one value with which you go and treat all patients with. I just felt that you're going to be giving all that fluid and it's just going to leak out into the tissues, and you end up with more systemic dysfunction than you would otherwise.
I think it's probably like a lot of stuff now, right? With fluid management in ICU, it's resuscitate and de-resuscitate, isn't it? I think the Royal up there, hand up.
Can you hear us?
Can you hear us?
Yeah.
Yeah. Neil, that's a great presentation. Thanks for doing that. Regarding the fluid debate, I think you could get sort of 10 to 20 intensivists in a room, and you'll probably get 10 different ideas. But what Vashti just said is absolutely right. It needs to be personalised to the actual individual that's unwell. Regards to giving huge amounts of fluid initially on the wards, I agree with Vashti. I think if you're getting to the point of requiring that amount of fluid to maintain a blood pressure, the patient should be in a high dependency unit and getting personalised care from an intensivist. And I think I think what in the past, it's all about identifying the high risk patients and getting them to HTU earlier, rather than having them on the ward for 24 hours, having lots of fluid and lots of conversations. It's just like, this is high risk. They're going to deteriorate. They need proper monitoring now rather than later. That's my feeling.
I mean, you could almost argue, and I've thought this for a long time, is that one of the main problems, and I guess this is I think because you guys see a very skewed view of pancreatitis, you don't see the 80% that are sort of come in and gone home without registering with you guys, because you see the 20% that were broken by the surgeons, that they kind of end up with you. And I almost thought to myself that what would be really beneficial, particularly for the juniors, and you know what, even for us, because we do have some consultants who are a bit old school, in that they very much believe that aggressive fluids right in the beginning. Everybody's dry, they need loads of fluids, and I think that just increases your ileus, increases your third spacing, it increases all the respiratory complications that they get, and then you guys are spending time trying to undo all of that and drying them out. And I think you could almost argue that anybody scoring 3 or 4 needs an early, almost like a HDU outreach kind of eye on it before we break them.
I think what you've said is spot on, Neil, in the sense that you have all that third spacing, you have you will get ileus with all that fluid that is going to get through the tissues. And the one study that you've said, some of the studies that you put up about, aggressive versus moderate fluid resuscitation in acute pancreatitis. So they actually did 20 mils per kilo as a bolus, and then followed it up with 3 mils per kilo as a maintenance fluid in one arm, which was the aggressive arm. And the second, the moderate arm was, half of that. So 10 mils per kilo as a bolus, and then 1.5 mil as a maintenance. And they actually had to stop that trial for the first interim analysis, and they had to stop it because there wasn't any difference in incidence of progressing onto severe pancreatitis, but the patients were so significantly fluid overloaded. So I think the evidence hopefully is slowly coming in that aggressive fluid resuscitation really isn't required. Recently, we've, Alex and Matt and Zoe, at the Brussels Symposium this year, they were also talking about how we tend to, even before we intubate, we tend to give them a big fluid bolus because we're worried about the hypertension post-intubation. But what they were saying is really, patients are hypoxic, there's a little bit of right heart strain, and you're giving them fluids when they actually need vasopressors with all the cardiac depressants you're going to be giving at the time of intubation. So Neil, I think as we're probably slowly moving away from generous fluids, even on ICU, even in other patient cohorts.
Awesome. Are you doing a presentation then, Rajni, or are you you're on mute? You're on mute.
Sorry, yeah.
Just out of interest, are you guys still using colloids at Glenfield?
We do, Alex. We do use colloids to some extent.
Why?
I know. You need to take it away from us. That's what you need to do.
Well, that's what we did here.
Yeah, we do tend to use them. We use them not really, not the way when you were a trainee at Glenfield, Alex. We don't have a breakfast of Has, to be honest. So because that has been taken away from us. So that they have restricted our access to 4.5% albumin, so we can't do that anymore.
Rajni,
but there are.
You have no idea how close I was to just putting you on mute then.
Am I embarrassing you, Matt?
I hear that the professor's still got a personal stash of Jello with Baxter.
Yeah, the professor does.
Which one? I don't know. I didn't know this.
Doesn't JT have a little stash of?
I didn't know. But I mean, we very rarely use it compared to years ago. We very, very rarely use it, but we still do use it though. To be perfectly honest.
I think it's quite clear that the starches are very, very bad for you, and gelatins are
yeah.
sort of really critical.
Yeah, I mean, we don't have any starches on the unit. Oh, we do have starches, so we do get. We do. No, we don't. Sorry, because we use colloids immediately on cardiac patients who come out really hypertensive, and we're struggling to get all the products and everything else. So we do use colloids in that situation, and they're all gelatins. They're not starches really. So we don't have access to starch. So I take that back. Matt will be relieved.
The only real patients that get colloids on the unit are probably the immediate post cardiac ones.
Yeah.
I don't think any of the general ICU patients ever get any colloid really.
No,
So
very rarely.
Your question on colloids is we agree, no colloids.
Yeah.
Although Neil
are you doing a presentation or are you not?
I don't think so, Matt, because most of what Neil has said is going to be a repetition in mine as well. So, it'll just bore everybody. So I think we could just go on to the journal club.
So yeah, unless anyone's got anything else they'd like to add from a pancreatitis point of view, that was a really, really good presentation. It was really, really informative and really helpful.
Thanks, Neil.
Neil, just a quick question. Do you guys, use prophylactic rectal non-steroidals when you do ERCPs?
Everybody gets PR diclofenac 100 milligrams unless they're asthmatic.
Okay, that was new to me. I didn't realize that.
Yeah, there's now lots of evidence out there that it prevents or certainly reduces the incidence of post-ERCP pancreatitis. There's established evidence now, so actually everybody should be doing it. Anything else, guys? I didn't know how to pitch it. I thought I had to do it so that you kind of get an overall bit of pancreatitis, because but it's actually really, when I was reading up about fluids and stuff, I thought I really need to know my stuff here, because these guys are on it, but it turns out you're just as clueless as we are.
Indeed.
Just one question for you, Kat, regarding imaging when somebody first comes in with acute pancreatitis.
Yes.
I take it, with the Balthasar scoring and CT severity index scoring systems, they take, you should be doing imaging at 72 hours. But do you just routinely CT anyone anyway, just to exclude other pathology?
Well, to be honest with you, most of our patients come via A&E, and they've often CT'd them before the amylases come back.
Yeah.
Do you know what I mean? They've almost got like a scanner at the entrance, haven't they? So anybody with severe abdominal pain who's coming through just gets CT'd really easily. And actually, back in the old days, when I was a lad, when I was in SAU, you waited for their amylase to come back, and it was 2000. You said, oh yeah, okay, fine, they've got pancreatitis. But now we actually do have CT at the same time. But what you shouldn't really be CTing anybody who's got obvious pancreatitis.
Yeah.
There's no point. There's no point. It doesn't predict severity in the beginning.
So do you do ultrasounds to look their biliary tree? Yeah.
Yeah. So the only bit of imaging they need, and back in the day, they used to get an abdominal X-ray, an erect chest X-ray, and an ultrasound scan. But the abdominal and erect chest has been replaced by a CT. But they just need an amylase, then an ultrasound, and a good history to see if they've been binging in, like the orange somewhere.
One of my concerns about the CTs on sort of just coming into resus is the fact that they're not particularly good at looking at CBD, are they? And so you might be disrupted. And
well, only 20%. Only 20% of patients are going to have a gallstone picked up on a CT scan. So they're going to end up having an ultrasound and an MR anyway. But I can't think, to be honest, Alex, we're so scan happy, it's ridiculous. It really is worth doing. Actually, gives me an idea. I might just audit it and see what happens with acute pancreatitis and the timing of CT and amylase results coming back. Because I think that we are too CT happy, because it's pointless. There's a lot of radiation, a lot of costs, and you're going to CT them in about 3 days probably anyway, because they're going to get a little bit worse and the CRP is going to go up.
Yeah. Thanks, Neil.
I had 2 quick questions, Neil. One is, in the post-cardiac patients who've been on bypass, we do see a transient rise in amylase in those patients. One, is that anything to be concerned about? Is it worth actually looking for it at all, or should we just ignore it? That looks like just ignore it.
I mean, depends on how high it is, but I've seen sort of, and I think it must be ischemia related, mustn't it? I can't think of what else would be causing it. But I guess you've got to take that into consideration with deranged LFTs, because that's the only thing I would say.
Yeah. And the second question was, from an ICU management point of view, one thing we do sometimes is look at intra-abdominal pressures.
Yes.
Do you think there's a role in doing that for these pancreatic patients more routinely, or is it not worth it?
No. So we had the ECMO guy, didn't we, come over from young lad who came over, and we were sort of toying with, I don't know, and correct me if I'm wrong, but I don't know how well intra-abdominal pressures are genuinely measured and how accurate they are. So actually, the last time, and all you would do for these people is do a laparostomia, which will take absolute months to heal, and there's a real pain to manage. So I think raised intra-abdominal pressures in acute pancreatitis is really overstated, to be honest with you. You know, when it's truly a problem, I think it's genuinely really rare. Nothing that can't be fixed with a good old-fashioned, well-placed NG tube.
That's
Hi, thanks very much. Great presentation. Thank you. So I've got two comments with regards to merit in measuring intra-abdominal pressure. I think there is a merit in measuring intra-abdominal pressure in pancreatitis for two reasons. That affects our hemodynamic goals because we shouldn't target mean arterial pressure. We should target abdominal perfusion pressure, which is the difference between MAP and intra-abdominal pressure. And the second is in the context of lung protective ventilation strategies, the plateau pressure that we have been targeted, which is usually less than 30, it's usually much higher. So we need to take into account the transmural pressure, which is the plateau pressure minus the intra-abdominal pressure. So that's why I think there is a merit. Obviously, if your patient is not paralyzed, it may be inaccurate, but if you have an intra-abdominal pressure of 35, it's highly likely that it's very high. Not necessarily 35, but it's very high. So I think trends in intra-abdominal pressure are meaningful, and that affects our hemodynamic and ventilation management.
I can't comment on the hemodynamic and ventilation side of things, but I will say that I don't think we do it. It's a bit, if you don't do something regularly, I don't think you do it particularly well. And I think unless you start doing on absolutely everyone and guiding your management that way, then the one patient who's got a query high intra-abdominal pressure, I don't think is always accurate. And that's the point I was trying to make, really.
Yeah, I think that is a fair comment, actually, Neil. We probably should do it maybe more routinely in those high-risk patients, so we get a bit more of a feel for it, and then we might have a bit more understanding about how to actually use the numbers. But yeah, I completely agree with what Baz has said as well. I think it does have a role, but we probably just need to know that we're basing our decisions on an actual genuine number or trend, because that's probably not always true. So.
Okay, so this is the paper that I was asked to, and thanks for asking me to present this at the Journal Club. This is a paper in 2014, which looked at an RCT comparing early nasoenteric feeding, tube feeding, against on-demand oral feeding at day 3, 72 hours basically. And the early feeding group was, the aim was to start feeding within 24 hours. So this was, like I say, an RCT. It had about 200 patients, 100 in each arm roughly. And it was a Dutch study looking at practice across 19 hospitals. Their primary endpoint was a composite of major infection, so infected pancreatic necrosis, bacteremia, pneumonia, or death within 6 months of follow-up. And their other interests were major infections and just death, and the rate of oral feed being tolerated. This is the abstract there, so I'll let you just have a read of that while I'm talking. What their findings were essentially in this, I would say, is a fairly well conducted and designed study. Their findings were that early nasoenteric feed was not superior for preventing infection or death in patients at high risk of complications compared with on-demand oral feeding. But I think there's quite a bit to unpick in the study, and I'm not sure how relevant this is to our ITU patients. It may have more relevance to ward patients, particularly bearing in mind this is looking at what you do with them in the first 24 hours. And a lot of these patients get referred to ITU, I think, after that period of time. So methodology and their interventions quite relevant. The nasoenteric feeding tubes were all nasojejunal tubes, and these were placed either radiologically or by OGD, and this was the local practice in those hospitals. And this was back in 2014, where it was a bit more up for debate whether this was the optimum feeding regime or not. The oral diet group had only IV fluids for 72 hours, but with the exception that if the patient requested food, they would get food. But there were only actually 5 patients that did ask for food in that time. The radiologists that were looking at the scans to determine presence of infections, obviously they were not blinded to the fact that an NG or an NJ tube might have been there or not, but they were not aware of the assignments of treatment or the actual studies arms. So that's potentially a relevant bias, but I think it probably was not having a huge impact on their findings. And it was analysed on intention to treat basis. The only patients that were excluded were those that had an external adjudicator decided that the diagnosis of pancreatitis was incorrect, and there were only 3 patients that fulfilled that. So, like I said, I don't think this is particularly relevant. Only about 20% of each group were admitted to ITU. So these aren't really, it's not a trial on ITU patients. Only a third of the nasoenteric group, only a third of the on-demand group actually went on to get NJ placement and feeding. It wasn't powered, and they explain this in the discussion, it wasn't powered to exclude a substantial benefit of early feed. And the results differed from previous trials. So there was, I think, quite a lot of the previous studies and then a subsequent meta-analysis before this trial took place were raising the feeling that early feeding and enteric feeding prevented infections and was beneficial, but that was compared with TPN, as far as I can tell. And I haven't done a full literature review of trials before and after this, but I think they were comparing TPN with enteric feeding, and therefore the benefit of enteric feeding wasn't necessarily the early feeding or the enteric route. It might have just been the absence of trying to feed early with TPN. They said that you might need to start the feed earlier to get the benefit. So I think they were really still pushing hard to try and prove that early enteral feeding was beneficial and find reasons why that might still be the case despite their findings. And they said that they needed a larger trial. So is it relevant to our practice? I think you can say that some of it is relevant because perhaps we see lots of people with pancreatitis coming to ITU, and we have to decide about how and when we're going to feed them. But I think mostly the results of this trial are not relevant to our patients. But by the time they come to ITU, they're probably at the point where they need to be fed, and that's not disputed, I would guess. And again, the reasons that most of these patients are not ITU patients, they were not in multiple organ failure for the most part. And specifically, they used NJ tubes in this trial as opposed to our normal practice of NG tubes. The latest review I could find comparing NG and NJ was a 2020 Cochrane review. And that basically says there's insufficient evidence today to say that NG or NJ are either superior, inferior, or equivocal. So I think there's really a lot up for debate about what's the best way of managing these patients. Does it change or confirm what we do? I'm not entirely sure what we do with these patients within the first 24, 40, or 72 hours of their admission. So clearly a lot of these patients are managed outside of the ITU. I couldn't find local guidelines about feeding. I know that society guidelines tend to recommend, including FICM, that is, tend to recommend early enteral feeding. But I think the evidence base for this is quite old, as old as this paper at least. Yeah, so I think that's really that's the main findings, why it's maybe not too relevant to this, to our ITU population, and the implications for our practice. I'm not sure we need to change what we're doing based on this paper, but I'm not entirely sure what we do in the first 3 days of admission. So I'll leave it at that. Is there any questions about that? And I'd like to hear the thoughts of Mr. Bardwine.
Go for it, Neil.
Yeah. So I mean, I covered it in my talk really, but the reality is that you're absolutely right. There is no evidence to say that. So the reason why NJ became in vogue is that it went past the ampulla. So theoretically, they said you're going to have less pancreatic stimulation with an NJ versus an NG feed. And if you remember, we talked about the exocrine secretion is all stimulated by duodenal and gastric distension. But actually, there's no evidence that NJ is better than NG. NJ is harder to place, so we stick with NG. And the bottom line is you need to get their calories in, and if they've got a functioning gut and they can eat, they eat. And if they haven't got they've got a functioning gut and they can't eat, they get an NG tube. I mean, that's pretty much it. It hasn't changed. I can't imagine it changing. And they always have a talk on this in every pancreatic meeting we go to, and it's essentially the same as what that article shows and several articles before it.
Thank you.
Good stuff.
Probably like every ITU meeting is always a talk about fluids.
Yeah, not 4.5% albumin though. That sounds like it's devil work.
No.